Hello and welcome back. If you are new to this channel, my name is Dr. Zayas. I'm a neurologist specializing in movement disorder. Today we are going to do something different. And this is the summary of talk I will give this week. I'm going to discuss the most common question, 5 questions that I get in the clinic. These are the 5 questions that we are going to talk today. Many of these questions we already have videos already published, but the information I'm going to give you today is updated, even though that I will repeat some of the information. The first question is Parkinson medication not working. Why is that? This is very common. Patients sometimes take the medication and they don't feel anything. It's like the medication is not doing anything for them. So I will give you 5 reasons, the most common reason for this to happen. Reason number one is maybe you do not have Parkinson's disease. You might have something similar to Parkinson's disease, but not Parkinson's disease. Not every Parkinsonism is Parkinson's disease. When I say Parkinsonism, I mean a slow movement. So you move slow, plus you have either resting tremor or stiffness. Resting tremor or stiffness. That's the big term that we call Parkinsonism. The most common cause of Parkinsonism is Parkinson's disease, but there are many other causes. So usually if you say that the patient has Parkinson's disease, when you identify Parkinsonism, you are correct probably 70%, 75% of the time. Okay? Now, what happened? Um, what other options or conditions can give you Parkinsonism? So there are many. There are many neurodegenerative diseases. So for example, PSP is the other one very common after Parkinson's disease, and many times misdiagnosed as a Parkinson's disease because sometimes during the first 5 years, you are not completely sure because things might change. And that's why sometimes you have to wait to see features that typically are seen in patients with atypical Parkinsonism. So typical means Parkinson's disease, atypical means any of these things here. Okay? Even medication, if I block dopamine, there are many medications that can block dopamine. You might look like a patient with Parkinson's disease, but you do not have Parkinson's disease. You have medication-induced Parkinsonism. And then I put here Lewy body disorder because this is like a spectrum um, between Parkinson's disease and dementia with Lewy body. So it's like a spectrum, even though that I believe there are different diseases. So that's the reason number one. Let's go to reason number two. Maybe your symptoms are too mild. So when you go to the clinic and you see a movement disorder doctor, a Parkinson doctor, you usually will have a number, a score. So we call that the UPDRS that you see here. If you have a low UPDRS, that means that your symptoms are very mild, so you don't have enough room to improve. So it's not the same thing having a patient with high UPDRS than a patient with low UPDRS. Those patients here, they have more probability to see more benefits because there is enough room to improve. They go from 40 to 20, so they improve 50%. So that could be a reason why you don't see significant benefit from the medication. And by the way, I'm talking about Levodopa, which is still the best medication that we have for Parkinson's disease, still in 2026. Reason number three is because Levodopa does not help every symptoms equally. So, for example, there are patients that they have a lot of tremors, a lot of resting tremor. And sometimes, actually frequently, probably 1/3 of the patient, the medication, the levodopa, doesn't touch the tremor at all, and they still have Parkinson's disease. Tremors are tricky because some patients respond very nicely and some patients don't respond at all. And there is no way to predict which patient will respond to levodopa in terms of the tremors. So that's very important that you understand that medication help more with the stiffness and the slow movement, the tremors so, and you should not expect that the medication is going to help with the balance. Walking, sometimes, okay? But the medication help more with the stiffness and the slow movement. The tremors, so, sometimes. Reason number 4, you are taking a very low dose. So you might be taking only half tablet 3 times a day. So many patients require higher doses to see some benefits. So you cannot say that the medication is doing anything for you if you don't reach good doses. And good doses means at least 600 milligrams of levodopa per day, which means 2 tablets of the 25/100 3 times a day. And some experts even say that you need to reach at least 1,000 in order to document, to say that the patient is not responding to levodopa. Okay, this is reason number 4. Let's go to reason number 5, why medications sometimes doesn't work for you. You might have problem with absorption. So sometimes there are patients, and this is not in every patient because this is a question mark. There is a lot of controversy about this, but what we know is that levodopa is absorbed in the same location, the same place that proteins are absorbed in the small intestine. So they compete. So that's why it's highly recommended that you separate from proteins. So you take your levodopa and you wait at least half hour, 30 minutes, and you eat whatever you want. That's the current recommendation. If you eat because you forget the pill and you ate, you have to wait approximately 2 hours. If you want to increase the probability of having better absorption. But there are some patients that they have enough receptors and they absorb the steak, they absorb the pill, and doesn't matter. So typically patients that have this problem with the interaction with proteins are younger patients and strong family history of Parkinson's disease. Okay? Now, one thing that you can do is, especially if you are having motor fluctuations, is to eat proteins, but later during the day, dinner time. Okay? So you see this picture here, not too much proteins here, not too much proteins here, and you see the steak here. Okay? So you eat proteins at the end of the day. So all the proteins, we call that protein redistribution. Okay? Now, very important this part here. If you are complaining of what we call upper abdomen burning sensation or epigastric pain, burning sensation, feeling nausea, bloating, feeling like a lot of air in your belly, burping, you might need to ask your doctor to check for H. pylori. Okay, H. pylori is a bacteria. And we have evidence that if you treat patients with H. pylori, against H. pylori, easily to treat, you might improve the absorption of levodopa, okay? And we have data for that. So sometimes the problem is not the medication, is the absorption. Let's go to the next question. How much levodopa is too much? This is a very common question that I get in the clinic. And again, I have a video of this, a full video of this, but I will tell you briefly. There is not such thing like too much levodopa. So there is not absolute maximum dose of levodopa. You take whatever you need to be functional, okay? Whatever you need to be functional. I have patients taking half tablet 3 times a day, half tablet of 25/100, the yellow pill, 3 times a day, which is a very low dose. And they are functional with that. But also I have patients taking 2 tablets from 7 a.m. to midnight every 2 hours. So we are talking about 18 tablets per day. So you see the difference? So you take whatever you need to be functional. Now, what you have to know is that if you increase the doses, the probability of having side effect or effect, whatever you want to call it, increase. Okay? So you need to be aware of the side effects. And when we talk about side effect, most importantly, when should you suspect that you're having levodopa overexposure? So too much dopaminergic state. So this is the thing that you have to pay attention. If you take your pill and 45 minutes, 30 minutes, you start moving, you are like dancing like this. We call that dyskinesia. Dyskinesia means abnormal involuntary movements. But in the context of Parkinson, we call that chorea, and sometimes even abnormal posturing dystonia as well when it's pretty bad. But usually it's chorea, and you see the neck moving like that, and patients are moving. And usually it's worse on the bad side. Remember, in Parkinson's disease, you always have one side more affected than the other one. Otherwise, you have to question the diagnosis. Okay? So this is usually what we call peak dose dyskinesia. There are different type of dyskinesia, but this is the most common type. This is 80% of the time you have a peak dose. There are other type of dyskinesia, which is other topic. The other thing that you have to pay attention that might indicate that you are taking too much levodopa is when you take the levodopa and you start hallucinating. You start seeing things that nobody else is seeing, or you start having delusions. Delusion means false belief that are not shared by others. That's delusions, okay? The other one is impulse control disorder. So you are gambling a lot, spending too much time in the internet, hypersexuality, eating too much, binge of eating, that kind of stuff. Number 4 is sometimes you take the pill and your blood pressure drop. Okay? That happens when you take too much at once. So individual doses. For example, taking 2 tablets. You are okay taking 1 tablet and you try to take 2 because you want to improve a little bit more, but you become dizzy or lightheadedness. So that means that the blood pressure drop. And this is why you have this sensation of lightheadedness and near syncope. Okay, you can actually pass out if your blood pressure drop enough that you don't get enough blood flow to your brain. Okay, we call that global hypoperfusion in the brain, and you pass out. You have to be careful with that because levodopa at high doses can cause that. And the other medications too, like dopamine agonists that I don't use too much in 2026. Excessive daytime sleepiness is another reason that might indicate that you are taking too much. You take the pill, and 30 minutes after, you feel sleepy. And you might have actually sudden sleep attacks. Okay? That's a peak dose effect. Now, let's talk about question number 3. What what is new in Parkinson's disease coming this year in 2026 or 2027? And I'm not going to talk about any medication or any treatment, phase 1 or phase 2, okay? Only phase 3 completed and one more that started phase 3 last year, which I have a gut feeling that it will work. So we'll see. So before that, let me tell you how these things work. When you are testing a medication, the medication has to go through phases. Phase 1 is you are testing if the medication is safe. Okay, medication is safe. Then you go to phase two. Phase two, if the medication help, you ask the question, does it help? That's phase two. And then you go to phase three, which is, does this medication really help, but in a large group? So we are talking about hundreds, thousands of patients. And then when you pass phase three is when you typically apply for approval, FDA. So there are some medications that it get approved in phase two, but this is exception to the rule. And in neurology, there are only few. Okay, I can give you medication for Alzheimer. One of them was approved phase two. And there is another medication, ALS for ALS, which was approved also in phase two, but it was removed from the market after phase three. I forgot the name of the medication. But this is very rare that a medication goes to from phase two to get approved. Okay, so usually phase three and then you submit. Okay, so the only medication in Parkinson right now that already passed phase three and we are just waiting for approval and probably will get approved hopefully this year during the summer is this medication that you see here, tavapadon. And this is a dopamine agonist. So the dopamine agonists that we have right now, which are rarely used, okay, rarely used. There are some patients still dopamine agonists. They have a role, but I personally don't like to use those medications because of the side effect that you get. So it's better to use levodopa, which levodopa is more potent and less side effect by far. Okay, but this medication is different because this medication work in dopamine receptor, but different receptors. The one that we have available currently work in D2 and D3. This one work in D1 and D5. Tend to be very specific and apparently, based on trials, less side effects. But still, you have the side effect that you get when you use dopaminergic medication. And actually, nausea, headache, and dizziness, you get those side effects from every medication that you take. So hopefully this is coming this year. So we'll see what happened. But that's the only medication that is coming right now. Okay. Now, I want to talk about this, and it's not a medication, it's a treatment. And it's this one here. Bendaneprocel. Very difficult to pronounce. Again, I don't know who is in charge of putting names of treatment and medication because people cannot pronounce names like that. So this is basically, this is not a pill. So, but I believe it is very promising, and I might be wrong, but it's a gut feeling that I have about stem cells. And the stem cells, basically, this is cell therapy designed to replace the dopamine producing neurons that are lost in Parkinson's disease. So that's the problem in Parkinson's disease. So somehow the neurons that produce dopamine are not working well. So the idea is to replace those neurons. And that's why hopefully this is going to work. So it passed phase one, it passed phase two with improvement, but remember, small group of patients, and now phase three. So, and this is basically Blue Rock Therapeutic. So there are many places in US. If you are interested to know more about this study and actually to be part of the study, you can go to clinicaltrial.gov here. Do you see that? And put, this is the name of the study, And then you can put location. And for example, in Tennessee, it's only one place, okay? Vanderbilt. But remember, and this is not a pill. So basically what they are doing is just you need to get a surgery for that. So it's the same type of surgery that you get when you are going to get deep brain stimulation. So it's a tiny holes that they do, that they make in your brain, your skull, go all the way to the deep nucleus that you have in the brain. We call that the putamen. And they put the cells there and wait to see what happens. Okay? That's the idea behind that. There is more complex than that, but I don't have the time to talk about details about this research. So now, next question is number 4. Doctor, I wake up at 3 a.m. and I cannot go back to sleep. What can I do? So this is very common in Parkinson and without Parkinson. Very common phenomenon. The first thing that you had to do is learn how to identify the cause. And you need to ask yourself a few questions before, okay? Because this is a very common phenomenon, again, with and without Parkinson. The first question is to ask yourself, are you wearing off at 3 a.m.? And when I say wearing off, is the medication, the levodopa, is out of your system, outside of your brain. So the brain is telling you, hey, give me my levodopa or I will wake you up. I will make you anxious. I will wake you up. Okay? There are different ways for the brain to tell you that. One of them is make you very anxious. So if you have a predictable anxiety episode, for example, every night at 2 a.m., 2:30, 3 a.m., you wake up very anxious and you cannot explain that. There's no reason for you to be anxious, but that time, you wake up very anxious. So pay attention to that because that might be an off phenomenon, especially if you're having more stiffness. So for example, when you sleep, normally you will move. That's normal. You move. But typically we don't wake up with that. But when you have Parkinson, you are very stiff, very stiff. So the probability of you waking up because you are so stiff that you cannot move too much increase. So that might be an off phenomenon. Also, some patients at 3 a.m., 4 a.m. wake up with a painful contraction, leg cramps, especially unilateral, one side, and toe crawling. Okay, and that could be an off phenomenon. We call that off dystonia. It's abnormal posturing, very painful. And the only thing that you can do with that, actually, the first thing to do is just to talk to your Parkinson doctor about this because they can adjust your medication, especially medication at night. There are many ways to improve this. Okay, maybe adding a long-acting formulation at night. There are many things that we can do. But talk to your doctor if you suspect that you're having 3 a.m. wearing off phenomenon. Step 2, you need to ask, okay, do you have overactive bladder? So it is normal when you get older that those muscles of the bladder are not working the same way as when you were 20s, 30, okay? So if you wake up one time at night to urinate, maybe twice, that might be normal. But in patients with Parkinson, many times they have overactive bladder. So this muscle of the bladder contract. So if the bladder feel like there is some fluid there, it will contract. It contract and wake you up. So basically, you have to go. You have to go. If you don't go, you pee on yourself. So the first thing to do is number 1, you have to learn how to make those muscles stronger. So try to talk with your physical therapist and ask about pelvic floor exercises. Pelvic floor exercises. Talk to the therapist because they will guide you. And if they don't know, they will guide you to the correct person. But this is very important because the bladder is also a muscle and you can get better just with that. Don't think about medication. So you guys need to see like medication is not the solution to everything. There are many steps before getting to medication, okay? And exercises and diet is the most important thing. Also, avoid fluid 3 hours before bedtime. Very important because imagine that you drink a little of water just before bedtime. It doesn't matter if you have Parkinson or not. You will wake up because you have to pee. So 3 hours, cut the fluid, just drink enough fluid for you to take your medications. That's it. If the symptoms are so severe affecting your function, then you might need medications. And then the medications, there are two medications to use. Okay, two medications to use. You have to be careful with this, with the medication that doctors prescribe for bladder, because there are many, actually, the majority of them are contraindicated. Well, relative contraindicated, especially if you have cognitive issues, if you have memory issues, because the cheapest one are anticholinergic medication. That's the medical term that we use for medications that decrease the chemicals in the brain, which is important for memory, like oxybutynin. Oxybutynin. That medication, oxybutynin, is a no-no for you if you have Parkinson. So if you have Parkinson and you need a medication to control your bladder, the medication to use is this one that you see here, mirabegron. Okay? Mirabegron or Vivegron. So they work in the same way. Beta-3 receptors agonist of the bladder. This one might cause high blood pressure. So if you have issues with the blood pressure, low blood pressure, this is the way to go, mirabegron. This one is not going to affect the blood pressure, vivegron, okay? Both of them are very expensive, but first choice, either or, doesn't matter. Except what I mentioned, what I say about the blood pressure. Then if these two are too expensive, try this one, which is trospium. Trospium is still an anticholinergic medication, but doesn't penetrate the blood-brain barrier. There's a wall that this medication doesn't penetrate. Okay, so you have the systemic side effects like constipation, but at least you don't have the memory side effects. Okay. Step 3, are you having vivid dreams? So vivid dreams is very common in Parkinson. Okay. But also you might have vivid dreams associated with acting out those dreams. So typically when you are sleeping, you are supposed to be paralyzed if you are in this stage that we call REM, R-E-M, rapid eye movements. You should be paralyzed except your diaphragm. Your breathing muscle is the only one, right? Because you are breathing, but the other muscles should be paralyzed. So when you are having a dream, in people with Parkinson, many of them, more than 55% of them, they are going to be acting out their dreams so they can wake up, because this is a very superficial stage of sleep. Okay, so you wake up easily. So this is a very common in Parkinson, and that might wake you up. So what to do? So if it's affecting your function, you can try melatonin, but be careful with melatonin, because melatonin helps with the REM sleep behavior disorder. Yes, it might help, even though that every time that I try, it doesn't do anything. But it might make the vivid dreams worse in some patients. So you have to be careful with that. What really works, and is the only time that I use this medication, is clonazepam. So clonazepam, I only use clonazepam for patients who are having severe REM sleep behavior disorder, acting out during sleep. This is when I use a low dose of clonazepam and work very well. Very well. And the majority of the patients work very well. The only thing is that you have to be careful with clonazepam because, number one, the risk of addiction, which is low, but still there, is a long-acting benzodiazepine. More balance issues. So especially when you wake up early in the morning, you might feel more like more disequilibrium, and also sleepiness. When you wake up, you still feel sleep. You still feel slow, like foggy mentally. Okay, so you have to be careful with the dose. These are dose-dependent side effects. Now, question number 4 that you need to ask yourself if you are waking up at 3 a.m. is, 3 a.m., 4 a.m. Do you have severe anxiety? Unrelated with levodopa, in the same way that people without Parkinson wake up. So that's a very common phenomenon. You wake up at 3 a.m. and then you need to ask yourself, well, I don't think that this is due to levodopa or actual Parkinson. And this is a regular anxiety, severe enough that you cannot sleep because you are thinking too much, thinking and thinking and thinking and thinking too much. You don't stop thinking. So if this is your problem, you need to treat that. You need to treat that. And sometimes it's very easy for me to tell you, oh, don't think about the future because I'm not the one, right? And sometimes it's very difficult. And many times when exercises and diet doesn't work, well, you need to try medication. So if you ask me which medication I will use in this setting and that I find very effective, especially when you combine with trazodone, is sertraline. Okay, sertraline and trazodone combination, it helps significantly to sleep in patients, and they are pretty safe medication from the Parkinson's standpoint. Obviously, you can have with sertraline, technically, you can have sexual dysfunction with sertraline, uh, but generally, sertraline is very well tolerated. It doesn't matter you are 100 years old. Just try to be careful with the doses. I typically start a low dose, even 25, and then go up. And many patients require at least 100 milligrams of sertraline to be effective if we are talking about anxiety. Trazodone, keep it 25, 50, 75, but no more than 100, especially in the setting of Parkinson's disease, and especially if you are over 65. But the most important thing to do before I forget is sleep hygiene. So what do I mean with the sleep hygiene? You need to go to bed at the same time. And I will tell you, try to avoid going to bed after midnight, unless you have a structure already. Like you go to bed at midnight and this is working for you, don't change anything. Whatever is working for you, you don't need to change anything. But I will tell you that try your best to go to bed at 10, before 10 p.m. 10 p.m. you need to be sleeping. That's your goal. Okay? So 10 p.m. you should be sleeping, and you typically try, your goal will be 7 hours. Okay? 7 hours. That's your goal. But don't put too much pressure on you that I need to sleep 7 hours. I need to sleep 7 hours. Because if you put too much pressure on you, things are not going to work well. If by any chance you wake up at 2 a.m., it's okay. Okay? Don't put too much pressure on you. It's okay. Next day is another day, and you will try your best, but don't put too much pressure on you. If you sleep 4 hours, it's okay. But your goal is 7 hours. The other thing is, if you are going to invest in something, invest in a good mattress. Okay? Don't order mattress online. You go to the store and test the mattress. Okay? Very important. And also the temperature. 68, 69, for me, that work. Okay? 72, 73, that doesn't work. So everybody's different. And before I forget, the other thing is make sure that you don't have a sleep apnea. Because if you have a sleep apnea and you don't treat that, every time that your oxygen drop because your airway collapse, your brain will wake you up. Okay? And this is nothing related with Parkinson. This is because you have a sleep apnea. So make sure that your doctor you need to screen for sleep apnea. So if you snore like a bear, if you have daytime sleepiness and you feel fatigue, you should get sleep study. And don't say that, oh, I cannot use this machine. There are many type of machine now, a lot of technology. There are even surgery that actually stimulate the tongue now. So those patients that cannot tolerate the CPAP, the machine that we use to avoid the collapsing of the airway, they are procedures that doctors are doing that. are doing currently. Okay, so no excuses. Now, the last question, and this question is one of the most difficult questions to answer, beside prognosis. Prognosis is another difficult question. And what type of exercises? And it's what to eat. What can we eat if you have Parkinson? And if there is any supplements. And the problem with this question is like all the research that we have, everything related with nutrition, especially in Parkinson, everything is observational. Okay, observational data. So we can tell you association. So for example, we can tell you that following a specific diet like Mediterranean diet and MIND diet are associated with delay onset of Parkinson's disease and Alzheimer. Yes, there is a clear association, but we cannot tell you for sure causation. Okay, causation. But association, yes. And that's the problem. And many times you are watching videos in YouTube of these biohackers talking about diet, and they look very well, they look healthy, handsome people with abdominals, 50 years old, and they talk very well, and then you get confused because you don't know if should I pay attention to these people or should I pay attention to my doctor, because they might give you different information. And then you don't know what to eat. So my view is that you should keep a balanced perspective. Okay, you can learn from both from your doctor and these biohackers too. Okay, I watch them sometimes, so they have good ideas and they emphasize, which is very important. That's why they look so good. They emphasize exercises, sleep, and diet. That's the three things that you can have almost full control. Maybe the sleep not too much because sometimes even we try our best and we cannot sleep well. But diet, yes, especially in US. Okay, and exercises, you have full control unless you have a very bad disease that you cannot do exercises. But even people in the ICU, they do exercises because physical therapy go to ICU. So no excuses. So I will talk about the mind diet, Mediterranean diet, the different, and what I follow. Okay, what I follow. So the mind diet is a diet that was designed in Rush University, Chicago, initially for Alzheimer, but it was found also to help patients with Parkinson. So basically, this diet delayed the onset of Parkinson's disease by years, especially in women, in ladies. But interestingly, the Greek Mediterranean diet was better than the Mayan diet for guys, for men. Okay, why? I don't know. Nobody knows, but this is what we have. So it's very easy to follow the mind diet. And I will tell you what, basically this diet emphasize that you need to eat these 10 type of food, okay? Eat more of these things. Eat more of these things, okay? The only thing I disagree is the red wine. The problem with the red wine is that, yes, we know that red wine comes from grapes, right? Grapes. And there is something that we call, and it's an antioxidant that we call revasterol. So this is an antioxidant that is high in the grapes, red wine, and basically we think that protect the lining of the vessels in the heart and in the brain. But you have to be careful because in a patient with balance issues, imagine that you have significant balance issues and you are taking alcohol, not a good idea. And the benefits that you get from the wine, you can get from another fruit without the toxic effect of alcohol. Alcohol is not good for your brain, except the red wine because of this antioxidant. But again, you can get the benefit of red wine with, for example, blueberries. Okay, and blueberries. So that's why I don't drink alcohol at all, because there is no benefits at all, and I don't need alcohol. So, and then this diet limit this type of food. Okay, so try to avoid this, or at least limit to no more than once per week if you are going to eat this. So now I will tell you what I follow. This is my diet. So I'm currently, at least during the last year, I'm trying to eat organic as much I can. And the key here is whole food. Whole food, okay? It's like eating from the tree. Eating from the tree. So every day I eat this. Spinach, lettuce, tomatoes, onion. I cook with a lot of onion and garlic. And I eat berries, especially blueberries and strawberries, every single day in the morning. And I mix that with Greek yogurt, organic. Okay. So I highlight the my diet. Okay. Highlight it, yellow. And red, and red is my modification. Okay. This is what I follow. So this is my, I will call it modified my diet. Okay. So I eat every day all these things that you see here. Okay. Organic coffee, a little bit organic milk, and a small amount of organic sugar. Okay. And then because I'm not a fan of salads, but I don't have any other choice, I have to eat it. So I use a little bit of dressing. Okay. Low calorie dressing. And nuts, nuts every day nuts. Nuts, they have a lot of antioxidants, good for your brain. Okay. And the one that the nuts that we have more evidence in terms of on brain health is the walnut. Walnut. Now, three times a week, I eat these things here. Okay, salmon no more than twice. Salmon has to be wild. Okay, avoid the farm raised salmon. Okay, there's a lot of toxins there, so avoid that. Wild salmon, and then beans. From where I came from, we eat beans every single day. Okay. Here I do it maybe twice a week, and with garbanzo beans. I eat chicken and turkey 3 times a week. Beef also 3 times I eat beef. Bottle, and this is the cheese that you should be eating, and organic if it's possible. Okay, organic. Uh, I never go to fast food. Never. Only when I was a kid. No alcohol, no candies, no soda, never soda. Snacks, no snacks. Especially a snack in the back, never. And I will tell you that maybe once a month, or maybe twice a year, I might eat this. Maybe ice cream once a month, yes. Pork, I don't remember when was the last time I ate pork. Now, this is the vitamins that I like to check in patient with Parkinson, because these type of vitamins tend to be low in patient with Parkinson. Number one is vitamin B12. Vitamin B12 tend to be low when you get older because the absorption is not the same, and levodopa somehow decrease the absorption of vitamin B12 as well, especially those patients that they have the pump. That we have now a levodopa pump, the sub-Q. So those patients are more predisposed to have vitamin B6 and vitamin B12 deficiency. Okay. So once per year, you should check these vitamins and replace. Don't take vitamins like crazy without knowing the levels, especially because vitamin B6, when vitamin B6 get accumulated, you might have neuropathy. Neuropathy. So high vitamin B6 and low vitamin B6 are bad for you. So vitamin B12, you have high vitamin B12, not a big issue, not a problem to my knowledge. Low vitamin B12, yes, that's a problem. The same apply to folic acid. Vitamin D also can get accumulated, so you cannot take vitamin D like crazy. Okay, your goal is to keep vitamin D levels around 50. So from 40 to 50, some people recommend over 50. I like to see close to 50, around 50. Very, very important. Now, if you ask me which supplement do I take, this is what I take. Okay, and this is what I buy. Okay, I don't get money from these people. Okay, at all, absolutely. But always make sure that the product that you buy they have a third party verification. Third party verification. Okay, this is very, very important because this is not approved by FDA. So basically, you have to believe on them. But this is a good brand. Okay, very good brand. So I take creatine monohydrate. I take magnesium. So creatine and magnesium, you have to make sure you don't have renal failure because otherwise you will have problems. Be careful with that. So make sure that you don't have renal failure, okay? Especially with creatinine and magnesium. Magnesium get accumulated when you have renal failure. If your kidneys are okay, you will eliminate. Okay, your kidneys can um, basically eliminate the magnesium when it's too much. Now, this protein shake, organic, I like it. I like the taste. Some people might have, I heard about diarrhea with this one. But this is the one I like the most. The taste is really good for me, and I mix that with almond milk, organic, and berries. Now, if you have kidney stones, calcium oxalate kidney stones, you have to be careful with this almond milk. Okay? If you don't have any issues with kidney stones, then you don't no problem at all. And then I like if I'm not eating salmon that week twice, so and then I take a pill of this omega-3 fatty acid. I like this one. Okay? Now, I will talk something for you to think, just for you to think about it, because I don't have any answer for this. And you can tell me in your comments what's going on here. So go and check life expectancy and healthcare cost in the world. So, for example, if you ask which top 5 countries have a higher life expectancy, these are the countries. Okay. Interestingly, this one and this one are located in the Mediterranean area, right? So they follow a Mediterranean diet. Okay. Hong Kong, China, right? The south of China, Japan, and South Korea. You see these people 86, 86, 85, 85. So basically 85 years old. This is the average life expectancy in these countries. It's amazing. Now, this is globally. Now, if you ask me about Americas, right? North, South, Central, Caribbean, these are the countries and territories. Okay, so I include the territories because Saint Barthélemy and Martinique are territories of France. France, okay? Canada is a country, so you see 54, pretty good. And this Caribbean, Caribbean, Caribbean. Now, Puerto Rico, number 6. Number 6 in America, okay? But globally, 41, okay? 41. And look at US, 62, 12 in America with 79. And then you need to ask yourself how this is happening, Okay. Let me give you numbers so you can understand this. So population in US is 340 million people, right? European Union, which are composed by 27 countries, the population is 450, mostly 450 million, right? 450. So it's like a 160 million more people than in US. However, we in US spend almost 3 times more money in healthcare, and we live less. So basically, we have, sorry for that, we have less life expectancy. So in US 79, and the average of European Union is 82, 81. So even though that you spend almost 3 times more in US, you have how many years? 2 years, almost 2 years, the difference. Why is that? That's a question, and it's not genetics. Okay, if you ask me what is the probability of you having a gene mutation, you have Parkinson, it's 12.5%. 12.5% of having a gene. So what about the other 88 or 87%? It's not genetics. So maybe it's what? Environmental, right? Environmental. And if you ask me what beside diet, because you might say, oh, these people here eat a lot of Mediterranean diets. They so and Hong Kong and Japan, even though that they don't eat that, but it's similar diet. They eat a lot of fish, a lot of green stuff. So they similar. And also for example in Puerto Rico, a lot of beans. But the main difference that I think is that any of these countries, all of these countries, they ban these things, toxins, okay? Like for example, paraquat. So all those countries that I mentioned here in this slide, they ban this type of pesticides, okay? Except USA. So we still use pesticides. We still use pesticides. And that's a problem. And that's why one of the things that I do and I avoid is using, or actually I don't use, I avoid things that contain DQuat. So you have to be careful. So don't go just by the brand. You have to read the label. So avoid labels that say DQuat, and Malathion. Malathion is another one. So we still sprayed our fruits with this here in US. Okay, so that might be a reason, because we know that paraquat is highly associated with Parkinson disease, highly associated. And there are plenty of data behind that. And this is even the worst. This is the worst. So this is TCE, and there is something that we call PCE that is still available in US, and people use it. This is a solvent, and it's used in paint, degreasers, dry cleaners. So and we know that this toxin causes Parkinson, or at least highly associated with Parkinson, because obviously so many people will tell you that there is no data that clearly cause this problem, but I strongly believe that something is going on there. And I strongly believe it's environmental, and time will let us know for sure. But I'm proactive. So right now I avoid uh, any type of products that contain this thing. So very, very important that if you have Parkinson, the first thing that you have to do that might help, actually, might help, because if this is the cause of Parkinson, you need to stop what is causing. And potentially, if you stop using these products, maybe even though that already your cells are not working well because you have already Parkinson, but maybe you don't progress as fast. I don't know. It's something to think about it. If you like this video, don't forget to subscribe to my channel. See you soon.